What do you recommend for a patient? Let's say that they want to maintain a good posture without getting all this problem.
There is this rule called the 30-30-30 rule.
What is an ergonomical chair?
Okay, ergonomics is the science of choosing your workplace according to your health.
How common is a belly fat as a reason for low back pain?
So let's assume a person who is supposed to be 70.
Okay.
If he is 85 or 90, he's got another 20 kgs extra. So whenever he bends and extends, the spine is the one which works against this 20 kg extra weight, isn't it?
What happens during menopause? What is the association between estrogen and bone health?
Estrogen, as we know, has this reproductive function.
Correct.
But other than the reproductive function, it has one more very important function, which is strengthening of the bones.
Or everybody who's reaching menopause should get a preventive DEXA scan to analyze.
Ideally, yes, sir. Maybe 45 plus.
There's another school of thought that milk is bad for you. What is your take?
This is news to me that milk is bad. If there is just a 1 kg increase in weight, there is not a 1 kg increase in the stress to the knee. It is 4 kg increase to the stress.
In addition to your fitness, you're also good in music.
Music is my first love.
Love.
Medicine is my second love. Will this come in the podcast?
Yeah. Before we dive in, can I be honest with you? It blows my mind that 57.9% of you who listen regularly still have not subscribed to our channel. If you enjoy the podcast, the stories, the science, maybe even laugh at our jokes, could you do us a small favor? Hit that subscribe button. It takes only 2 seconds and helps us keep bringing you better guests and episodes every week. I'm truly blessed to have all your support, and I'm sure you will support me in the journey. Now, let's get into today's episode. Hello, sir. Welcome to the podcast.
Good morning.
Thank you. Thank you for being here. We are so excited to ask a lot of bone-related questions to you.
Okay. It's a pleasure meeting you. I'm a die-hard fan of
Oh,
you.
thank you. That's so nice of you. That's so nice of you. My when I spoke with your wife, she's also a doctor, and she said that make sure that he follows intermittent fasting after the episode. So I'll start right off the bat that all these questions were being actually asked by my audience, by my subscribers. Okay, major question what they had was, as an orthopedic doctor, when you go to any functions or get-togethers, your family and friends will come and say, I have neck pain, I have back pain, what is the treatment? Will they ask that?
Yes, many a time I ask them to meet a good orthopedician. So yes, but yes, it is because back pain, neck pain, knee pain nowadays is pretty common. Pretty common not only among the older age group but also among the younger age group. Considering the fact that the lifestyle has become pretty sedentary nowadays, especially with the IT field coming up. So a lot of people have back pain, neck pain, knee joint pain as part of their daily routine. So I try to help them with simple basic advice. Basically, it is lifestyle modifications, exercise restrictions, not much of medicines, but basically like changing of the lifestyle, exercises, posture correction, etc., which most of the time corrects most of the problems.
Most of the problems. Mainly posture is very important, correct?
Absolutely, sir. Especially so in the younger age group nowadays, since the advent of the computer and the IT department. Almost like 10 hours a day, all of us, the IT, mainly the IT group, they are always in the sitting posture, isn't it?
Yes.
So it is like 10 hours per day in the office, and maybe another 2 or 3 hours at home. Again, they still do their home, all the home activities also done with the laptop nowadays.
Correct.
Or with the device.
Correct.
So it is like walking, standing, the number of hours that we do that has reduced much. And because of this, a lot of times there is neck pain, back pain, hip joint pain.
What do you recommend for a patient? Let's say that they want to maintain a good posture without getting all this problem. So will they have to keep a reminder to themselves to sit straight, or what do you usually say?
Yes, sir. Especially for this people who have this sedentary lifestyle, work-wise, office-wise, there is this rule called the 30-30-30 rule.
What is this?
30-30-30 rule is take a break for about 30 seconds every 30 minutes and look at something 30 feet away. So it's like, that's because what happens is like if you sit for a long time in the same position, we naturally tend to stoop down.
Correct.
And our neck goes down. We don't sit in the erect posture, and that this is the actual posture which we adopt after 30 minutes. So if this posture is going to be there for 4 hours, then it is definitely going to cause both neck pain and back pain. So once every 30 minutes, it's a reminder to get up from your chair, walk around a few steps, take a 30-second break, not a coffee break, maybe a 30-second break, do a little bit of stretching, get back, sit in the proper posture. Look at 30 feet away is for the headaches. I mean, people have eye strain looking at the laptop or the screen which is close to the eye. So if they look at something distant, there is the strain to the eye reduces, the headache reduces.
I see.
So it is usually called the 30, or it can also be the 45 break if you can't take a break every 30 minutes. So this is a simple technique. And also ergonomical chairs, you know what they are. I mean, these chairs, they are like this is not an ergonomic chair. We need to have the proper chair with the proper.
What is an ergonomical chair?
Okay, ergonomics is the science of choosing your workplace according to your health. So that is called ergonomics, isn't it? So, or rather, altering your workplace to suit your health. So when you spend about 10 hours in a day sitting in a chair, it makes all the difference at the end of the day how you end the day based on how you sit. So ergonomically designed chairs are commercially available. A lot of things, 4 or 5 points. Most important is the seat height. You need to be able to lift and reduce the height of the seat so that the feet rests on the ground. It should not be hanging. There should be some gap between the thigh and the. There should not be pressure in the back of the thigh when you sit. So the feet should be sitting. Placed on the ground. Sometimes if the seat is too high, the feet does not sit on the ground and we hang it on the air, leading to a lot of pressure in the back of the thigh, leading to both hamstring tightness as well as a sciatic nerve compression, the nerve compression. The next thing is the back support should be curved. It is like the normal shape of the spine is not straight. It's curved. It is called lordosis. So the back of the support also has to have the curve, which reproduces the actual natural shape of the spine.
So two curves, cervical curve and the lumbar
As well as in case you have the headrest, it is the cervical curve too. Mainly it is the lower back lumbar lordosis has to be reproduced with the help of the chair.
So I'm just going to summarize that. So there are two curves in the spine.
Yes.
One is the cervical curve, which is near your neck area.
Yes.
Second one is the lumbar curve, which is on your low back area.
back area.
So you're telling us that when you're choosing a chair, make sure that the low back is also curved.
Yes.
And if you have a headrest, then you also have that neck curve.
Neck curve.
So the chair that you are sitting right now is not ergonomic.
Yeah, because it does not have the curve. It appears to be straight.
Please change it, okay?
But we are going to spend only 1 hour here. So the next thing is the armrest, sir. The armrest is also important. We need to have an armrest which matches with the height of the table, because when you use the laptop, if you don't use the armrest, you need to keep your shoulders elevated and do the work like this. And the muscles of the neck, the trapezius, they are always under stress. Maybe the arms are like, my upper limbs are like 10 kgs each. So, but if I rest the arm in the armrest, the trapezius or the neck muscles, they relax. And I need to just work from the wrist level, not at the shoulder level. So again, that leads to, when you have a proper armrest at the same height as the table, it reduces the strain on the neck muscles and the shoulder muscles, reducing long-term neck pain.
Neck pain. When you buy a chair, you should buy a chair with an adjustable armrest.
Ideally, because
you don't know the height of the table.
Yeah, the table keeps changing. So we can either lift it up or lift it down so that it is the same level as the table, and there is no difficulty in placing the arm as well as using the laptop at the same height.
I'm elevating the seat so that your feet
are rested at the ground so that there is no pressure on the thigh, backside of the thigh or the hamstrings. Second thing is the back support.
But for that seat needs to be lowered, right?
Sir. We need to bring it down.
Bring it down.
Bring it down. Keep it at the appropriate height so that the feet does not hang in the air.
Yeah, okay. So the seat needs to be lowered so that the feet is on the ground.
Rest comfortably on the ground.
On the ground. And then armrest should be adjusted so that the
table height and the
table height and the arm are the same
not
thing.
Too much strain to the neck muscles, the shoulder muscles.
And if you have a headrest, make sure you have that curve over there as well.
Both in the lower spine as well as in the neck.
And I've seen people buying the low back device where they can keep it in the chair.
Tighten it.
No, in the chair,
Okay.
they can add on.
Yes.
So let's say they don't buy an ergonomical chair.
That's because the office doesn't spend too much to change the chair. So people, because they can't buy the chair by themselves, the office has to provide. So they do a little bit of compromise. The chair remains the same, but they just keep the support. The support is what they have themselves. They take it with them on a daily basis to the office.
I think it's a wonderful thing.
That is also a good thing. Sir.
That's what I'm saying.
The most important thing is the way we sit. Whatever chairs we have, beautiful ergonomic chairs. If you sit like this, doesn't make a difference at all
see.
because we are not using the curve. We should be sitting erect so that we use the curve, and it's supposed to be like the entire back has to be rested in the backrest, so that the actual shape of the curve of the spine is. The chair helps us to reproduce the actual shape of the spine.
So my friend who's like 41 years old, he called me and said that I have the worst back pain ever. Is that common?
Sir, multiple reasons for back pain. So almost 70-75% of short duration back pains, less than 1 month, less than 6 weeks, are mostly muscular. And they are related to the posture, related to lack of activity.
No, this friend was well the day before. And he woke up and then he had the severe back pain.
So severe back pain preventing you from doing your day-to-day activities. Such severe back pain cannot be ignored. Such severe back pains, definitely he has to see the doctor or a physician or an orthopedician to make sure there aren't any serious issues leading to such severe pains, like an acute disc bulge.
Disc bulge.
Okay, that is the commonest. Acute disc bulge, which
So tell us about this disc in the spine.
Okay,
What is a disc in the spine?
So the spine, as you know, the spine is made up of multiple bones, one lying just below the other. Between the two bones, you have this cartilage substance or a cushion between the two bones called the discs. So these discs are not bones. They are
Disc
made up
is the
of
same as cartilage.
Yes, sir. It is cartilage. So it is fibrocartilage. So the bones, when you bend and extend the spine, the bones cannot bend. Bones are as hard as stone. Okay, they can't bend, they can't flex. So where does the movement happen? Movement happens between the two bones at the level of the discs. So these discs are necessary to allow the flexibility of the spine, allow the movement and little bit of elasticity of the spine. But sometimes what happens, because of heavy lifting, heavy activities, or due to other conditions, the disc loses its elasticity and it bulges out from its place, causing compression of the spinal cord. The spinal cord is just behind the disc inside the spinal canal. So a disc bulge is a condition where the disc comes out from its usual place, causes compression of the spinal cord or the nerve, leading to severe pain. Sometimes there is numbness, a weakness of the legs too, pain radiating down into the leg, otherwise called sciatica. So that's a difficult situation. That cannot be treated simply at home with just restrictions and rest. That has to be seen by the doctor.
How common is a belly fat as a reason for low back pain?
Belly fat, there are two things in belly fats, and when you say, two things come to my mind. One is obesity itself. So people with belly fat usually are obese. So obesity itself leads to multiple reasons why there is back pain, because of the maybe like 10 kgs, 15 kgs extra.
Is it because of the gravity that is pulling down in the front? Right?
That is the second point, sir. The first point is the obesity itself, which is the weight gain itself. So let's assume a person who is supposed to be 70.
Okay.
If he is 85 or 90, he's got another 20 kgs extra. So whenever he bends and extends, the spine is the one which works against this 20 kg extra weight, isn't it? So even bending down and taking a weight or taking something from the floor, the spine has to do additional 20 kgs. So that is one reason why obese people get back pain. The next thing is, as you say, when the patient is obese, the lordosis, that is the actual curve of the spine, becomes more exaggerated because of the belly fat. As you say, the gravity, the belly fat, it pulls the spine forward.
So the curve would be like this.
Yes.
What is a normal degree? It's around like 15-20.
15-20.
Because of the belly fat, it becomes 35.
More, okay, 25-30. And the person becomes like this, because the fat pulls it front. And because of this, the spine has an exaggerated lordosis. And because of the exaggerated lordosis, they have back pain. The same thing happens in pregnancy too. Pregnancy, again, the last 3-4 months of pregnancy, there is this exaggerated lordosis because of the big uterus, the child is inside. And because of the exaggerated lordosis, there is pain in the back. So that is why the last 3 months, most of the pregnant ladies experience significant back pain.
We joke that, you look like 9 months pregnant, but in terms of back pain, it might be the same.
Yes.
Okay, super. I want to touch base upon women and bone health. Okay. So we really wanted to know more about
I've heard most of your viewers are women.
women. You know why?
Because you're so handsome.
That is absolutely not the reason. Because many are they are finding it difficult to lose weight because of the hormonal imbalance. Estrogen, progesterone, we men are actually lucky
Yes,
that we only have testosterone.
There is no menopause.
There is no
as such.
menopause. There is no, every month menstrual period doing with, estrogen phase, follicular phase, luteal phase, nothing. The reason that I feel that my time restricted feeding method, intermittent fasting, works for women mainly is because they feel benefit much earlier than men because of their disordered hormonal imbalance already.
Okay.
So what I see commonly is that when they are hitting menopause around like 45, the first thing they are worried about is this bone health. What happens during menopause? What is the association between estrogen and bone health?
Definitely, sir. That is, it's common. I mean, it's like, it is otherwise called perimenopausal osteoporosis. Osteoporosis is a very common term nowadays. Most of us know what it is. Osteo means bone. Porosis means the density of the bone becomes less. The density of the bone becomes less around the menopausal period. That is why it is called perimenopausal or postmenopausal osteoporosis. Estrogen, as we know, has this reproductive function.
Correct.
But other than the reproductive function, it has one more very important function, which is strengthening of the bones. So the bone has two types of cells. One is called an osteoblast, the other is called osteoclast. The osteoblast is the bone building. Osteoclast is the bone removing. So estrogen has effects on both these cells. It inhibits the osteoclast, which means prevents removal of the bone, additional removal, and it helps in the addition of the bone.
Explain more why a bone should be removed.
So there is bone turnover, sir. That is just like any other organ, the bone is also, whatever skeleton we have today is not the skeleton we'll have 6 months later. So some of the cells die, some of the cells are added, isn't it? Just like it's called turnover. So this turnover is
Like a balance.
Where some of the bone is added, some of the bone is removed. So when removal is more than what is added, they develop osteoporosis. So this estrogen has this inhibitory effect on the removal. It prevents removal. So it acts on that level and therefore it prevents loss of bone. But when the estrogen is gone following menopause, the removal happens at a much accelerated rate. The formation happens little slower. So that is why osteoporosis happens around menopausal region, menopausal time period. Especially so if the patient is already having obesity or if the patient has steroid intakes, etc.
In your patient population, do you think men or women, which group has more osteoporosis?
Definitely women. Sir. Definitely women. As you say, because of the fact that men don't have a classical andropause. So it is a prolonged andropause like 55 to 66 or 60 to 70. But women have a classical menopause. Just like 2 or 3 months, the period stops, the estrogen stops functioning. So because of this sudden stop of reproductive function and estrogen production, definitely women are the ones who are more prone for osteoporosis when compared to men.
Okay.
One more reason, testosterone itself by its nature is much more osteoblastic and it provides more impetus for good bone strength when compared to estrogen.
Osteoblast is formation of bones.
Formation of bones.
Formation of bones. Nice. So in osteoporosis, let's say a woman is reaching a menopausal stage. When should be concerned that she has osteoporosis, or everybody who's reaching menopause should get a preventive DEXA scan to analyze?
Ideally, yes, sir. Maybe 45 plus. 45 plus. Most of the women, there is no direct rule that everybody has to undergo the DEXA scan, but it is ideal that women after 45 years of age, maybe once a year or once in 2 years, they need to do the DEXA scan, make sure that their osteoporosis is, make sure that their bone density levels are normal. In case there is some difference, it is called, the beginning stage is called osteopenia. So when it is just at the stage of osteopenia, it is easier to correct, prevent it from becoming classical severe osteoporosis. It is better or ideal for women after 45 to do probably an annual DEXA scan to rule out early osteoporosis and correct it before it becomes severe.
Yeah. Well, one important thing that you're listening to this, if a person who listening to this podcast, if you're more than 45 plus, my recommendation is to get a DEXA scan as soon as possible to analyze the body fat percentage that you have, because I did.
My recommendation too.
Yes, orthopedic as well. Because when I did the DEXA scan, I did for my body fat percentage distribution.
Yes,
okay. It is 2,500 rupees in Chennai.
Okay.
On an average. In the US, it's $100.
Which is about
Around 8,000 rupees.
Okay.
Okay. But we use coupon because we US people are very good in coupons. So if you're a person who is listening to this podcast from the US, you go to Groupon, there will be like 20 to 30% discount. $40 to $50 will be the scan. So if you're 40 or 45 plus, the DEXA scan will give you a number, correct?
Yes.
To analyze the osteoporosis. Please educate us about those numbers.
So it is called the T-score. So it is called the T-score and the Z-score. So these are both statistical values. There is this concept called the bell curve statistics. The one subject which we left it in choice, mathematics 10 standard. Statistics. Okay. So it is called the bell curve. So -1 standard deviation on the either sides. -1 means almost 95% of the population comes within the first standard deviation. So anything above -1 is considered -1 standard deviation. T-score more than -1 is considered osteopenia. So -1.5 plus, it requires definite treatment.
So the number usually comes as -1.5,
exactly.
2.5.
T-score more than -1 ideally needs to be treated.
So more than -1 is osteopenia, more than -2.5 is osteoporosis. So let's say we do a DEXA scan, and in my experience, every patient that I did DEXA scan for an Indian women around 45, almost 90%, is around -1.5 to -2.5.
Yes, it is widely prevalent.
Very prevalent.
Very widely
Very
prevalent.
prevalent. The fact is that they will not know it.
Yes, sir.
They don't know it. So let's say a person does a DEXA scan after listening to this podcast, and let's say it becomes -2. So they're not osteoporotic yet, and they are osteopenic, which means they can progress to osteoporosis. What will be your treatment suggestion for that particular period?
So osteopenia also needs to be treated. Osteoporosis definitely so. Osteopenia too. So we start with good exercise.
Super.
Okay. Good food that is protein rich.
When you say good exercise, it's like 3 times a week.
I mean,
What is the routine?
20 to 30 minutes per day of active cardio exercises. Okay. Not necessarily weight training. A little bit of strength training and a little bit of cardio, both. Exposure to sunlight if possible.
When you say cardio, walking?
Yes, sir. Walking is the best. I usually suggest walking.
Walking.
But some people, if they're a little younger, they go to the gym, they do the exercises like treadmill, running, jogging, Zumba dance, etc. But the older people, 50 plus, 60 plus, the best exercise is walking.
Walking.
I ask them to combine it around 3:34 in the evening so that there is also exposure to sunlight. So both walking walking as well as exposure to sunlight, they can combine at the same time. So good food is like, I always say, bone is like a PVC pipe. PVC, protein, vitamin D, calcium. Nice. So easy for us. I mean, that is how I remembered when I was studying earlier. The mnemonics. So P stands for protein. Protein rich because bone is made up of collagen. V is vitamin D. Also vitamin K. Vitamin K2. So vitamin 2 vitamins. And C is calcium. Calcium. Along with calcium, you can also add magnesium.
A question on the collagen. So people think that only skin has collagen.
No. Bone is made up of the bone, almost the entire structure of bone is made up of collagen. Collagen, type 2 collagen.
Type 2 collagen. And that collagen is being stimulated by nice protein consumption.
Yes, collagen itself is a protein. So collagen itself is a protein which can be built in the body only if you take adequate protein in our diet.
1 gram per kilogram per day is something.
This is the usual recommendation.
Okay. But in this patient population, maybe a little bit higher is better?
The Indian scenario, 1 gram per day itself is a little tough, sir. So unless we take additional, if you
supplements with the whey protein powder,
it's difficult to reach 1 gram per day itself in the Indian, because many of us are vegetarians. We don't eat much meat.
Correct.
So 1 gram per day is ideal for people who want to have a little more muscle.
1 gram per kilogram per day.
1 gram per kilogram per day. If I am 70 kgs weight, I need to take 70 grams of protein per day. But those who want to really build up muscle, those who want to build up bone strength, they can go up to 1.5.
1.5.
Which is like almost like 70 kg person taking like 120 or 125, 100 to 125 grams of protein per day. Which is pretty difficult to achieve in the Indian diet.
Of course.
Because it is not much of non-veg.
Yeah. So we can say the best recommendation is to at least make sure you get 1 gram per kilogram per
kg
day
body weight of protein.
Okay. So we were talking about the protein. So 1 gram per kilogram per day. In your practice, how do you teach your patients to get it?
So I suggest that they take 1 gram per kg per body weight per day. But as I already mentioned, it is pretty difficult to be practically possible in the usual Indian diet. So I suggest that they take, sometimes I ask them to take protein supplements. Both in that, there are commercially available protein supplements. I ask them to take egg whites, paneer, cheese, legumes, patani, all the sundal varieties, peas varieties. All these are the regular protein. Milk. So these are the regular.
So there is another school of thought as milk is bad for you. What is your take on that?
I don't think so, sir. Unless you are lactose intolerant or if you have allergy. I think
how important milk is for the bones?
Definitely, sir. Milk is very important because it is calcium. As I said, of the P and C, both of it is available in milk.
Protein and calcium.
So not only milk but also all dairy products like curd, yogurt, paneer, cheese. All these things are rich in both protein and calcium, which are a vital part of dietary requirements for healthy bone. So I never ask them not to take. This is news to me that milk is bad.
It's a multiple social media reels have been postulated that milk is bad for you. And I'm just thank you for supporting the evidence that milk is not bad for you unless you are lactose intolerant.
Yes. So I'm not much of a social media person. So only as you say, I
you should be on social media because you need to burst all these myths. That's why you should be there.
Okay. So milk is the most natural, one of the most natural foods available, isn't it? Even for newborn babies, that is what the mother feeds.
Correct.
But then how can it be bad?
So the other argument is that, human species are the only species drinking milk from somebody else other than mom. For example, cow's milk.
Okay.
So they are arguing that, that is not a normal natural source. But from a nutritional standpoint, milk is rich in PVC, protein, vitamin D, and calcium. So from a bone standpoint,
definitely
milk plays a key role.
It's a little surprised that somebody says milk is not good.
Right. But not those energy drinks, like we'd say, you drink milk, you grow taller.
Okay. No,
not that. Okay, super. So I'm just summarizing what we talked about. So P we finished. V is vitamin D.
Vitamin D is also very important. Vitamin D is like a catalyst. It's like the one which helps in the bone metabolism along with calcium. Calcium and vitamin D, they go together like husband and wife. No, husband and wife don't go together. Okay. So they go together all the time. So vitamin D helps in absorption of calcium. Like we take calcium and it needs to be absorbed in our intestines into the blood, isn't it? So vitamin D is the one which helps in absorption of calcium from the diet into the body. Also absorption of calcium from the in the kidneys we lose calcium.
Correct.
So in the urine. So this vitamin D prevents the loss of calcium in the urine. Reabsorption of calcium in the kidneys also happens because of vitamin D. One more thing is vitamin D, not only bones, it also has multiple other functions, not only in the bone, the skeletal system, but in the cardiovascular system, neuro system, also as a hormone in multiple areas. So not just for the bone, it is like more or less like a hormone influencing multiple areas of the general health.
Is there an average calcium intake per day?
Definitely, sir. So it's about 1 gram per day.
1 gram.
1 gram per day is the recommended dose, especially postmenopausal.
Usually comes in 1000 milligrams.
1000 milligrams. 1000 milligrams per day. Similarly, the dietary requirement of vitamin D is around 750 to 600 to 800 international units per day.
In your practice, do you recommend any person coming to you after 45 plus to take calcium and vitamin D, calcium supplements? Just calcium?
Usually, I don't if the patients are not symptomatic. So ideally, we need to do serum calcium levels and serum vitamin blood tests. Blood test of both calcium levels and vitamin D levels before prescribing on a long term. I usually prescribe them for all of the patients after 60 years. If they come for a fracture surgery, for helping in the fracture healing, I definitely prescribe. But for younger patients around 40-45, unless they are symptomatic, I don't prescribe.
Is back pain a symptom?
Yes. Yes. So if they are symptomatic, I either do blood calcium levels, blood vitamin D levels, or a DEXA scan, confirm the presence of hypocalcemia or decreased calcium, and then treat them for calcium.
Super. Is knee pain is a symptom?
Sometimes yes. But more commonly, knee pain is a symptom of osteoarthritis, not osteoporosis.
It's a beautiful segue to our next segment.
Okay.
What is the percentage of patients walking into your office has osteoarthritis of the knee?
So maybe about, I see about 20-25 persons per day on a daily basis. Almost like 5 to 7 or 5 to 8 of them have knee osteoarthritis.
You work at Kamakshi Hospitals?
Yes, Dr. Kamakshi Memorial Hospital, Pallikaranai.
In Chennai?
In Chennai.
And when you say 20-25 patients per day, you also have your surgeries?
Yeah, 25 is the number of outpatients I see every day. Okay, surgeries maybe around 3 or 4 a day or 2 or 3 a day.
I was like, how does US practice come to Chennai? Only 20 patients a day. That is not the case.
I have restricted myself only in the mornings. I don't practice in the evenings. So evening is for my personal time.
Wow.
Exercise, music, reading.
You're one of the few doctors who have made sure the quality of life is good.
I don't know. Maybe I'm one of the few doctors who are pretty lazy, not willing to work in the evenings.
No, work-life balance is very critical until you make a very conscious decision.
So since you asked me, I started practicing 2005 as an orthopedician at Dr. Kamakshi Memorial Pallikaranai till 2013 or 2014. That is what I used to do. I used to work in the evenings too, right from morning 8 to evening 10. Late night 10. So at around 10 years down the line, something clicked inside me. I decided that so much of work is not good for work-life balance. So I stopped practice in the evenings. So I usually wind up my day around 6 p.m. Wow. After 6 p.m., I have a team of about 5 or 6 orthopedicians who take care in the evenings, the orthopedic needs of the hospital. My practice usually is over by around 5:36. And evenings are dedicated, as you say, for work-life balance.
I wish in the US there's a system where the evening doctors come in. They come only in the evening.
Okay.
They don't come in the morning.
Mornings. Okay.
The morning doctors, they're just only in the morning. Okay. They don't come in the evenings.
So I think it's a matter of personal choice, but most of us choose work over
life.
Work
over
life balance. Okay.
Yeah, and that is an unfortunate situation. I wish it changes significantly. So let's say you see like 20 patients a day. You're saying 7-8 patients osteoarthritis. That is around close to
30%,
25%,
25%, 20%.
And many are women.
Yeah, it is around like 2:1 or 3:1. Women, predominantly women, yes.
But men also come.
Yes.
Men also come. And they come in with knee pain.
Knee pain, knee deformity, that is, they walk with the bent knee. The knee is no longer straight, it is like bent like this. They walk like with a lurch. They are unable to do their day-to-day activities. they can't climb upstairs. Even activities of daily living like using the restroom, a lot of pain. They can't go out for a walk. So every single day of their life, they spend with pain. The pain becomes part and parcel of their life. It significantly reduces their quality of life.
Yeah.
And they are living with a disability, like almost 30%, 40% disability for many, many years.
Yeah, my audience is very young, but we are also seeing young osteoarthritis of the knee.
There are two types of arthritis, sir, since you started this topic. So the younger age group, less than 40, 35, 40, that particular group, they are more commonly, the arthritis is called inflammatory arthritis. The older age group, 50 plus, that is when the osteoarthritis comes. Osteoarthritis, inflammatory arthritis are two different classifications based on the root cause. Osteoarthritis is wear and tear, degeneration, which happens universally for all people. So anyone above 60, almost all of them have osteoarthritis with varying degrees.
Explain a little bit about the wear and tear. What is wearing? What is tearing? Explain about the cartilage and the bone for us, please.
Okay. So the bone, just like we have enamel for the teeth, in the joints, the bone has a protective layer. The protective layer is called cartilage. It's about 2 millimeters thick in the knee joint. It is just like the tiles that we apply on top of the floor to make it shiny and smooth. Similarly, the cartilage is very shiny, very smooth, and it helps in proper functioning of the knee joint without friction, without pain. So just as the bone turns over, that is, there is addition of bone, removal of bone, the cartilage also undergoes a turnover. So there is formation of cartilage, removal of cartilage, right from the younger age group. But around 50, 55, what happens is, just like the bone, the turnover of cartilage undergoes a change. That is, the removal of cartilage is more than the formation of cartilage. So as a result of which, there is gradual depletion of the cartilage layer, and as long as the removal is more than the formation, around a few years, 55, 60, the patients land up with zero cartilage or near zero cartilage. So irreversible loss of cartilage in the joint is called arthritis. So this happens in the older age group because in the older age group, the recovery of cartilage is not as good as the removal.
Once the cartilage is lost, it cannot be replaced.
There are two types of cartilage loss, sir. One is called a reversible loss of cartilage, otherwise called chondromalacia. This is a term which is the common term for knee pain in younger age group. 40, 35, people with knee pain, anterior front of the knee pain, they can't exercise, they can't jog. So that is called chondromalacia, which is a reversible loss of cartilage. This with proper treatment, the 100% recovery is possible.
Okay.
But when the same loss of cartilage is irreversible, that is called arthritis. That is what happens 50, 55 plus.
How many people come early and how many people come with late?
Most of the Indian scenario, most of the population which comes to the doctor for treatment for osteoporosis, usually it is grade 3 or grade 4, that is the late stages. Early stages, they do have knee pain, but they learn to live with the disability. They don't come to the doctor immediately. They realize that it is just part and parcel of aging and they don't do much about it in the early stages. But when it becomes really difficult, like when the pain becomes a part of their everyday life, when it disturbs their day-to-day activities, so only then they come, which is usually the late stage. It's a grade 4. Grade 4 is the last stage. So that is when they usually come. Sometimes, of course, grade 2, grade 3, and the younger age group who wants to have an active lifestyle. But predominantly, it is grade 4, which is the severe arthritis.
Where it is being graded based on the loss of cartilage.
Based on the X-rays. We do weight-bearing X-rays based on the X-ray. It is divided as grade 1, 2, 3, 4. Grade 1 being the earliest. Grade 4 being the last stage.
Okay. When a patient is having knee pain, when should we come to you?
When the knee pain is troubling you too much that you can't manage it by yourself at home.
Okay.
Sir.
Okay. What are the things that we can do to manage at home?
Restricted lifestyle, rest, weight reduction, exercise, hot water massages, ice compressions, external ointments, physiotherapy at home, stretching exercises. There are multiple modalities of treatment which can be done. I mean, for early arthritis, most of the time, 90% of treatment is what you do at home. It's only going to be simple medications for just 5 days to 1 week to reduce the initial pain. But then most of the time it will be lifestyle restrictions, lifestyle modifications, weight reduction, exercise, physiotherapy, hot water massage, knee braces, knee supports, etc., which will make it all right.
So how does weight play a role in osteoarthritis?
It's very important. The most important advice or suggestion that I give for people to avoid a knee replacement in the future, especially those people who are overweight, is reduce your weight. So whatever advice I give, the most important advice to prevent knee arthritis becoming severe enough in the future so that you can avoid a knee replacement in the future is reduce your weight.
80-90 kilo patient is coming with your osteoarthritis. What is the target weight that they should come down
So
to?
let's assume the patient is supposed to be 75 kgs.
Correct.
Based on the height. And if the patient is 90, so it's about 15 kgs
Correct.
extra. So it's been found out by research that each 1 kg increase in body weight increases the pressure in the knee joint by about 4 kgs. Okay.
Wow.
So each 1 kg additional, because the knee is a lever arm, isn't it? It's not straight. So it bends, it extends, it carries your weight. There is an impact loading whenever you run. So the knee does not, if there is just a 1 kg increase in weight, there is not a 1 kg increase in the stress to the knee. It is 4 kg increase to the stress. So if you are like 10 kgs extra, it is like the knee is working 40 kgs more when compared to what you're supposed to be if you are a normal weight. So a person who is supposed to be 75, but he's 90, he is like 15 kgs extra. So 15 into 4 is 60 kgs extra. The knee is put to a strain of almost 60 kgs extra because of this extra 15 kgs. So that is the major reason why obese people land up with osteoarthritis at an early age.
Wow.
So weight reduction, there are modifiable factors, non-modifiable. So of the modifiable factors, the most important that we can modify is weight. And of course, the second is exercise. Non-modifiable, genetics, family history, age, these things you cannot modify. But the modifiable, most important is weight. So almost always the first advice to prevent osteoarthritis, weight reduction. Second, weight reduction. Third, again, weight reduction. Only then comes exercise, dietary restrictions, dietary modifications. So the weight plays a very important role in reducing the incidence of severe arthritis, both prevention as well as in the treatment.
Wow. You know, my dad had osteoarthritis and he's from Madurai, and he was postponing the knee replacement because he was grade 4 osteoarthritis. And I've been recommending him to get it for a long time, but of course he didn't listen to me. But eventually, he has to do because it was impairing his quality of life significantly. The main reason that he didn't want to do was he was scared about this knee replacement. It's a big surgery, and people are saying that it will fail, we'll have to do again. So I know that you are one of the most successful robotic knee replacements here in Chennai. Tell us a little bit more about the robotic type.
So joint replacement, we all know that it's been there for like 40 years now all over the world. So I've been doing joint replacements manually almost for the past 18 years or so. Maybe I would have done around 3,000 joint replacements in the last 18, 19 years.
3,000?
But around 3,000, both hip and knee together. So, but I've been doing it manually all these years. So at Dr. Kamakshi Memorial Polyclinic, we've got this robotic joint replacement facility installed about 6 months ago, not 6 months, 5.5 months ago. We have the Mako Robo, which is from the company Stryker. Stryker is a world-renowned multinational company dealing with joint replacements. So this is one of the highly advanced robotic technology is Mako, M-A-K-O. So that is what we got at Kamakshi, and I've been doing it for the past 5.5 months at Kamakshi. We've done close to 80 to 85 surgeries in the last 5 months. So the results are amazing when compared to manual. So whenever you do a manual surgery, there is this element of human error. Whatever surgeon, whatever experience, whatever skill you have, there is always this 5 to 10% chance of a little bit of a human error creeping in because of various factors. So when you do a robotic surgery, this robo almost always completely eliminates this element of human error. So for example, the commonest complication in hip replacement is dislocation. Following the surgery, the hip dislocates, the ball moves out of the socket. The usual rate is about 10%, 5 to 10%. Like
dislocation is then
the ball and the socket, both of it is artificial. So in the first 1 month, the ball comes out of the socket. That is called dislocation. It's a major complication. The usual rate is about 5 to 10%. That is 1 in 15 they dislocate. Even for the best hands, even in the best of hands, even the most, maybe in the best hands it is 5%. In a little less it is 10%.
10%.
So I'll give you a question. So following robotic surgery, how much would you think the percentage is reduced? Like from 1 in 10, it has now reduced to, tell me what could it be?
So you say 1 in 10. So I would say maybe 1 in 20?
No.
1 in 30?
Third chance.
1 in 50?
1 in 1,000.
1 in
So
1,000.
from 1 in 10, this joint replacement, especially in the hip replacement surgeries, the complication rate, which is the commonest complication that the surgeons are, which is the dreaded complication, which we don't want it to happen at all. So from 1 in 10 or 1 in 15, it has come down to 1 in 1,000. 1,000. So which is a pretty drastic reduction in the complication rate. Similarly, the same is the story with the knee replacements too.
Post-operative recovery?
So again, when compared to manual surgery, it is almost double the time better recovery. It is like 30 to 40% decreased blood loss, 30 to 40% decreased pain, and immediate recovery. The patients are able to walk in 2 or 3 days, sometimes even without the walker in 2 or 3 days.
So recovery is faster.
Recovery is almost double the time faster when compared to a manual surgery.
Do you recommend doing both knee replacements at the same time?
In case both the knees are severely damaged,
Correct.
most of the patients have both knees severely damaged.
Yeah.
So when both knees are severely damaged, it's always ideal to do both knees at the same time.
Super.
You can't walk with one knee, isn't it? You need to have 2 knees to walk. So if the both knees are...
No, the risk-wise...
Yes, sir. That is important. So what we do is before the surgery, there is always this risk assessment. So the anesthetist, the cardiologist, they all have a look at the patient. They give the risk assessment. In patients who have significant cardiac, renal problems, severe diabetes, maybe it makes sense to do 2 knees, one after the other, 3 months, 6 months apart. But for most patients who are generally fit, with a reasonably good level of fitness, it is always better to have both knees done at the same time.
Same time, okay. Can you just tell us a patient experience where the robotic knee replacement changed the life?
So robotic knee replacement, the basic difference between manual knee replacement and robotic knee replacement is, in robotic knee replacement, we can do a personalized, customized knee replacement for each single patient. In the manual knee replacement, whatever be the preoperative anatomy, whatever be the preoperative structure of the knee, we bring the knee to a average shape. Okay. So that is the goal of the manual surgery, to bring any knee damaged in any ways, however severe it is, to the average shape. But then the average is not the normal for the patient, isn't it? So in robotic surgery, we have this option of restoring the actual native original shape of the knee joint as much as possible, even after the surgery. So the originality of the joint is maintained. We don't bring it to an average shape. We bring it to the original pre-arthritic shape. You understand what I say? Both in terms of alignment, balancing, as well as resurfacing. That amount of precision is not possible in manual.
Wow.
So that is one of the major advantages of robotic surgery. The next advantage is there is a virtual surgery which we can do even prior to the actual surgery. That is just like a simulation. So the robo understands the bony anatomy, the ligament balancing, the overall alignment, even before the joint is placed in the bone. So before actually placing the joint, we can do the surgery in the monitor.
Wow.
In this particular angle, what would be the final result? The joint, the monitor will show us as to how this alignment, the balancing would be even before the surgery happens. We can do changes. We can alter the surgery. We can even do 10 times simulation surgeries to get the exact parameters that is matching to the patient's anatomy. And once we get the exact parameters, we can reproduce it exactly using the robo. In manual surgery, we have only one option. We do it only once. We cannot change it. But in robotic, we have this option of simulated surgeries. Just like a video game, we can do the surgeries on the monitor before we actually reproduce it in the original patient. So that is a wonderful advantage where we can correct all the errors which might creep in during manual surgery.
So it's a myth segment.
Okay.
So I'm getting a second opinion from an orthopedician.
Okay.
So number one, menopause only affects mood and hot flashes, not bones or muscles.
Wrong.
Okay. Looking younger is the same as being biologically younger.
Not always. Not always.
Not always. Because I have seen many people, most of the time when they look young, they have taken care of themselves. And, fitness is one of the main thing.
Okay.
But sometimes genetics also matters a little bit more.
Looking younger is the external features, isn't it? So biologically young is your systems. The systems, the cells, how they function, how they are in harmony with each other, whether you're able to maintain the overall metabolism of the body normal. That is biologically young.
Correct.
Looking young is just outside, isn't it?
Yeah,
That is-
but if you are young, biologically young,
usually
most
it is,
likely you
usually
look-
it is they look young too.
the older
Like
you...
Dr. Pal.
Yeah. Actually like you. The older you get, the more dangerous exercise becomes.
No, wrong. So that is we need to choose our exercise. So it is like as we become older, we definitely have to exercise, but the type of exercise keeps changing as you get older.
Nice. For osteoarthritis, steroid injections will cure arthritis permanently.
No, they give interim relief, maybe a few months, 6 months to 8 months.
How often they can keep on doing that?
Maximum twice a
3-4
year.
times? Twice a year.
Twice a year, maximum twice a year, but not usually after. We don't usually do more than 2 or 3 injections.
Losing weight is more important than gaining muscle.
That's a tough one. Yes.
So, because as you said, 1 kilogram weight loss will prevent 4 kilogram additional strain on the
Yes.
knees. That's a mind
And
blowing.
gaining muscle is not as easy.
Yes.
The losing weight is easier.
Slightly easier.
Gaining muscle is not as easy as losing weight.
Correct. Flexibility does matter, but not as much as strength.
Yes.
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 In your case, when in your orthopedic practice, when somebody bends down and they're not able to touch the feet, is that considered as a lack of flexibility?
No.
Okay.
They can work on that, but I don't think I can do it either.
But do you promote flexibility exercises?
Yes. Flexibility
right? Stretching.
exercises, basically they are like range of movement or flexibility exercise and strengthening exercises. Both has to be done for all people, but based on the age group and the demand of the particular patient, it changes. The percentage of strengthening and flexibility keeps changing.
Changes.
That is the work of the physiotherapist.
Got it.
That is where they come.
Once your knees hurt, exercise should be avoided.
No.
That's a very common myth.
So exercise is like a double-edged weapon, sir. Irumunai vaal. So if done properly, they make it better. If done very aggressively or without proper monitoring, it makes it worse. So we need to be careful about how we do exercise, especially after you get the knee pain.
Okay. I want to really ask you this. You look really fit. Okay. You
Thank
don't
you.
look like you're 47 years old. You
Sir,
look...
I'm 27.
You're
sir.
27.
You see there are a lot of viewers.
You look
Okay.
like you're 27. What do you do? What is your fitness routine?
So I've been working out right from my school time. I'm the third of 3 brothers. So both my brothers, they're senior to me. They were all exercise. When I was in school, both of them were in college and they were already exercising. So I just followed them maybe.
Right
and I
from
started
childhood.
exercising around when I was in the 10th standard. That is when I started.
So I strongly believe that the early you start, the
Very
better
important.
it is. Yeah. And the factor to make you start early is your environment.
Definitely.
Because your family.
Family and friends makes an important impact. And then I'm also careful about the diet. I eat everything, but in moderation.
You do.
I don't cut sugars. I don't cut coffee. I love coffee. I take like 4 to 5 coffees, but I cut the sugar in the coffee.
Nice.
Similarly, I eat everything, but I eat everything in moderation. I do exercise maybe about 5 days a week.
5 days a week.
5
What
days.
time?
Evenings, 7 to 8 or 7:30 to 8:30 before my dinner.
Before
7
your
to
dinner.
8.
And is it weight training?
Yes, mostly it is. So now I'm in love with this particular equipment called the Kettlebell. You might have heard of this Kettlebell. So Kettlebell is one exercise which combines 3 factors, 3 different parts of the exercise. That is weight training, that is strength, flexibility, as well as cardio and stamina. All of the 3 can be achieved, in my opinion, with just this single exercise. So if you usually go to the gym, the first 45 minutes, the gym master asks us to do the weight training. The next 5 minutes, it is cardio. Not 5, next 15 minutes cardio. And the last 5-10 minutes, flexibility and stretching. So the 3 different things that we do every day which takes about almost like 1 hour. But in kettlebell, it's like a little bit of a cheat. So what we do only 30 minutes. In this 30 to 25 to 30 minutes, it's all the three combined. We can get cardio, flexibility, as well as strength training with kettlebell. It's a wonderful. It's like a very interesting exercise. It's not like a routine. It's like a dance.
Yes.
It's like a dance.
Yes.
If you can see the videos of kettlebell exercises, they are very interesting to do.
Yeah.
Okay.
It's amazing. I love Kettlebell. There is a company in the US. It's called Bowflex.
Okay.
It's not a sponsored video. Bowflex Kettlebell is what I recommend to all my patients in the US.
Okay.
It ranges from 5 kilos all the way up to 50 kilos in a single kettlebell.
Yes.
So you can modify it.
So since you talk about the kgs, I started with 8 kgs about 5-6 years ago or 6-7 years ago. Graduated to 12, 16. Now I'm doing up to 24.
24.
Yeah. Wow. So we have a family of kettlebells from the smallest to the largest, like right from 5 kgs up to 24 kgs.
Nice.
So,
Wonderful.
So I have now started recently.
So do you recommend anybody listening to this podcast, if they have to start somewhere, maybe they can look into the kettlebell exercise?
Definitely, but with proper
monitoring.
Kettlebell is also an exercise which is injury prone. If not done properly, a lot of injuries to the wrist joint, to the back. So they don't want to start with huge weights. They start with minimal weights, get the form right, ideally with the teacher to teach. I mean, I did not start by myself.
Correct.
I went with the trainer. The trainer trained me for about a few months, after which I started doing it myself.
So we have an online gut health program. Okay, it's called New Me. That is a program that I started in my hospital in California. It's called Preventive Gastroenterology.
Okay.
In there we teach about gut diet health and all those things. But one thing what we have put together is a virtual gym.
Okay.
Where anybody can join anytime in different time zones because they're all around the world.
Okay.
And there are multiple trainers that are training for like 30 minutes to 1 hour. But majority of them do kettlebell.
Kettlebell.
Okay.
Somehow kettlebell has not picked up much in India. I don't know why.
It is picking up now.
So
we recommend to buy a kettlebell at home.
Okay.
That's only simple kettlebell.
Simple kettlebell. Yeah. We both can be kettlebell ambassadors.
Yes.
We can share videos of our kettlebells exercises too. Okay.
In addition to your fitness, you're also good in music.
Music is my first love. Medicine is my second love. Will this come in the podcast?
Yeah.
To be honest, music is my first love.
The first love.
Yes. I started music when I was in the second standard.
Wow.
I started with vocal music. Then I learnt violin. I can also play the keyboard a bit. I can play the mandolin a bit.
Wow. Nice.
So, but of course, violin is my favorite instrument. I still play the violin.
Super.
But I no longer play the Carnatic. I learned Carnatic music. Nowadays, I play more of light music and cine music.
Wow.
So it is just for my own. It's passion. I don't learn it anymore with any gurus, but I do it. I play it myself at home.
Nice. So we're going to use your violin.
Yes.
To teach the relationship between osteoarthritis, so my audience can learn it even better.
With music.
Nice. Okay.
Nice.
All right, that's good. Super. You've taken your violin and you look like a fit violin enthusiast. Beautiful.
Thank you.
Beautiful. So I'm going to give you a situation. Okay. So we talked about osteoarthritis. So osteoarthritis, you said that bone is like this. Cartilage is over it.
On top of the bone.
And if you don't take care of the cartilage slowly wears out. But when we are born, cartilage and bone and cartilage are together.
True.
Okay, together.
True.
So they are living in a harmony.
Yes.
Okay, for this harmony, I want you to play a nice, beautiful, harmonious melody.
So message through music. So harmony between the bone and the cartilage.
Beautiful. Beautiful. Wonderful, sir. Wonderful.
Very famous interlude from movie Punnagay.
Of course, everybody who follows Ilayaraja will know this. You're beautiful, beautiful. So this is how cartilage and bones are in harmony. Okay, and bone also needs another thing that you talked about, muscle. Okay, and that is not a harmony, that is a love. So bone is loving the muscle, because only when the muscle is there, bone is protected. Okay, not only in terms of strength, in terms of endurance, in terms of mobility, flexibility, everything you need muscle. So bone is in pure love.
Bone
Yes.
is singing this
Now
song to
we
the
have
muscle.
love song. But since we have done with Ilayaraja, I want something with A.R. Rahman.
It's a love song. Okay. Happy love song.
Be love song.
A.R. Rahman.
Oh, nice. Beautiful. Bone is saying muscle. Strawberry kanne, right?
Bone வந்து muscle.
So now this is where we are born. And then, 10 years, 20 years, this harmony and love is there. And starting from the 20th year is where we get into software engineering, sedentary lifestyle, medical doctors not following circadian rhythm, and slowly the love and harmony is getting repaired.
நம்ம மேரிட் லைஃப்ல சொல்றீங்களா?
Married life.
இல்ல ஜெனரலா சொல்றீங்களா?
Marriage between bone, muscle, and the cartilage together. Okay, so when they're getting damaged, pain and everything starting to come. So now
Just like all marriages, it also fades away.
so the bone is crying now. Okay, you were muscle and cartilage. You are with me now. Now at 40 years of age, you are not with me anymore. So it's crying.
40 இல்ல சார் ஒரு 55 60.
50, 60. ஆமா. சரி, okay. 50, 60. At this time, a sad song that the bone is singing to cartilage and muscle. Please come back again. Any A. Rahman or Ilayaraja, what do you want?
Sad songனா இளையராஜா தான்.
Ilayaraja. Beautiful. Wonderful. Oh my God.
Thank you, sir.
Nice. See, doctors can also do other things, okay? Thank you so much.
you,
You've been
sir.
wonderful
It's
guest.
been a pleasure.
It has been pleasure. I think we learnt a lot, and I'm hoping that we will have another podcast with you pretty soon. Best wishes. Keep curing those knees. Keep doing these robotic surgeries. Kamakshi Hospital and all your good work should be recognized. Best wishes.
Thank you so much, sir. Thank you so much.
Thank you. Thank you.